courses, particularly my second exam, a little bit of my first, but pathology later exams, ENT, you're gonna start seeing more paragraph, vignette type questions, giving you pieces of information and then asking you to pull out what is important in order to answer the question, right? That can get challenging from a time management standpoint when you're trying to take these exams in 75 minutes. I'm gonna say this here, and I'll say it again throughout the course. My recommendation for test taking strategies when you start to get to those questions is read the STEM first. What are we looking for? Ignore the 3 or 4 lines of paragraph in the question. First go down to the last statement. Are we looking for, in this case, imaging, right? But in some courses, are you looking for a diagnosis? Are you looking for a treatment? Are you looking for a next step in treatment? Maybe not the medication, but like what's the next thing we should do based off of imaging or whatever? What are we asking for? Then read the 5 answers. Put yourself in a mindset, right? You have the benefit as a student to go, well, I don't have all the possibilities in medicine because they can only give me 5 choices. So read the 5 choices first. Put yourself in that mindset of this is what I'm looking for. Then go to your vignette. Then start picking out the stuff that can rule in or rule things out. Because sometimes when you read your 5 choices, you may put yourself to a knocking 2 out or knocking 3 out down to a 50-50 already. For example, in radiology, if I give you a right shoulder x-ray and you know it's right, and I have left something on there, you could already rule that out. So now you're not trying to sort between 5 answers, you're trying to sort between 2 or 3, right? So try to use that to your advantage from a time management standpoint. A little bit about myself. So I came through this program. I know I haven't really met a whole lot of you yet. I came through this program back in the day. Sat in 1, 2, 3rd row up against the wall, so good seat choice. Yeah. Prior enlisted for 8.5 years before I came through here. Was a former radiology tech. Ironic. Any radiology techs in here? Prior before getting here? No. Usually have at least one. All right. When you raise your hand, it means I don't call on you on things because you already have a little bit of advantage there. So did that for 8.5 years. Came through this program. Succeeded, obviously, here. It was a struggle, so I know what you're going through, right? But if I can get through it, you guys absolutely can. All right, I was not a 98 average person. I was like a happy like 85, all right, and I was okay with that. But came through with a wife and 3 kids at the time. Youngest was 2 months old, oldest was 6 when we did this program. So went through a lot of some of the stuff that maybe some of the challenges you guys are dealing with if you have families in that aspect. Happy to talk about that if you need to. Went out and practiced family medicine for about 6 years. Came back here, did my education doctoral fellowship. So my doctorate in education here at Fort Sam and stayed here. And so now I'm here on podium teaching you guys. Born and raised Chicago, and love all sports and love radiology, right? This is an abstract topic. It's kind of like a guess what I'm thinking type thing. So we're gonna get through it together. I'm gonna do a lot of, they fixed this, I'm so excited, they didn't have this last semester. I'm gonna do a lot of drawing and a lot of circling, erasing, and circling again to help train you to see what I see, okay? Because what's gonna happen when you get out to clinic is you're gonna order x-rays and you're gonna order CTs. You're gonna order ultrasounds and MRIs too, but those are a little bit more advanced outside of some basic ultrasound interpretation that we're gonna cover here. You're not really going to be expected to read your own films when it comes to MRI and ultrasound in a family practice or outpatient setting. So we're going to go over it a little bit to know what they look like, because you got to be able to tell the difference between the different modalities. But as far as X-ray and CT goes, those are what you're going to need to interpret. Because what can happen is you'll be out there in the field, either deployed or by yourself, and you're going to order an image. And yes, there's a radiologist somewhere in cyberspace who's going to read that. But it could take them up to 2 to 3 days to get that back to you, depending on what their workload is and what's going on. But you got a patient sitting in front of you right now, and you got to tell them whether or not you think it's broken or what else is going on. And so that's going to be on you to be able to interpret and read the film to give what we call a wet read, which is basically you're reading it and then waiting for the radiologist report, and that's what we're going for here. So we'll go through it at a slow pace if we need to, ask lots of questions. I'm here to try to help you guys kind of see this stuff. All right, so we'll jump in from there, and that clock is clearly broken in the back. I have my phone up here, so I'm not a big fan of going overtime into the break. So if it hits like 52, like in minute wise, and I just haven't looked at my phone because I'm on topic, somebody like wave a white flag, we'll throw you guys on break, even if I'm mid-topic or something. But that clock's not working, so I'll do my best. Perfect. All right, so let's get started. So radiology, right? The study of pictures and bones and all kinds of other stuff. Block 1 is going to be mostly MSK and intro stuff. Block 2 is chest and abdomen. Block 2 is more challenging than block 1, right? Don't listen to your juniors and seniors who talk about the horror stories of radiology. Don't listen to your seniors, talk to your juniors who just did this class last semester. They did really well. Why is block 2 harder than block 1? It's a little bit more challenging just because there's a lot of things that go on in the chest, and we'll talk about that when we get there. But what it is on block 1, look at your slideshows and Canvas. I have 3 intro slide decks, right? Those are my first order, cookie tossing, like easy, straightforward questions. There's just no way around asking those except for what color is this on x-ray or what is this, right? Well, because those are this block, guess what I don't have in block 2? 3 intro slide decks. So just by the nature of the material, it's more meat and potatoes than it is in this one, and that's what makes block 2 a little more challenging. But we'll get through block 1 together. So this is what we're going to be looking at. By the end of this course, you will be able to interpret almost all of these images. Right? Almost all of these images. These are not all the same person. There's something together. And hopefully recognize this. All right? Now you're sitting there going, sweet, radiology is easy. They're not all going to look like this. All right? They're not all going to look like that. But the goal is, even when there is something subtle, that you guys don't have to wait for a radiologist read, you can be able to treat it. That's the nice part about this course. Guess what we're not really going to talk about this semester in this course? Treatment on most of the stuff. I may mention it in passing, but that's going to be for ortho. That's going to be for pulmonology, cardiology, GI, over there in that room next semester. We are not focused on a whole lot of treatment in this course because I don't have the room to teach it, and they do. This is going to help you more pull out what's wrong, and you'll learn more about treatment next semester. These are some of the things you might see in the ER. All right? And the question that you may not be able to answer now is, so they ordered the x-ray, that's great. What does that tell us? It tells us where the nails are, right? And a couple of things, this shows us why 2 views are important, and we'll talk about those orthogonal views later, right? Because I have image 1 and image 2, which only one of those would never really tell me where exactly those foreign objects are, right? Because it's a 2D picture, so I can't really, this looks like it's just right down the center in the front of the skull, I can't really tell. And then when you look, it's actually more towards the back because of the second view. So we'll talk about that. But then also, so I can see the nails, do you think this imaging tells me the extent of the damage in this patient? No. I probably need to get something like a CT to really look at the extent of the damage. That's the kind of stuff we're going to learn here. All right, how do you succeed in this course? You already had A&P. I'm not covering it again. Now, when we get to the MSK slides, and when we get to block 2 and your chest and abdomen, you will have slides in your slide deck that have the anatomy and physiology pictures from last semester. That's there for you to have easy recall to remember and study. I'm going to blow past those because you already had A&P last semester, right? But it's really important to know it for this course because when you're trying to pick out where the fracture is, what bone is affected, those kinds of things, that comes from your A&P knowledge, all right? Attention to detail, very clear. We're looking at for small little abnormalities, right? So attention to detail is huge in this course. Systematic approach we will cover. What does that mean? That means read an x-ray every single time the same way. Whatever your way is. There can be, however many we have in here, 67, whatever it is, different ways to do it, right? Don't care. As long as for you, it's your way, the same way every time. That's how you don't miss things, okay? Don't just memorize my pictures. I promise you, the pictures on my slideshows will not be the pictures you see on the exam. Do not just memorize the pictures, which brings me back to testing. How many use the app to take their tests? Nobody? Usually there's at least a couple. Okay. Please test out your browser, your web browser, to take exams through Canvas. Do not use the app for my exam. The pictures is too much bandwidth. The app crashes every single time because there's going to be pictures because you got to interpret x-rays. So if you haven't used a web browser, Safari, Mozilla, whatever it is to take tests before, please test that out and make sure it works well to get to Canvas before our first exam with radiology, all right, because you're going to need to use that. I will have pictures on the test. They will not all have pictures, okay? There will be at least one normal x-ray answer on the test. Because finding the normal, nothing wrong with it, is just as important as finding the abnormality, so you can tell the patient I see nothing wrong. There will be at least one. Which means when you submit your test, you should have at least one normal x-ray chosen out of the choices. Do not have none, because there will be at least one. We usually have at least one exam question that has where the 5 answer choices are 5 different pictures. Right? To where I give you what's going on and I say, hey, pick out this fracture. And then you gotta pick the one that coincides with it. Not a lot of those, usually like 1 and 1 or 2 normals, depending on what the exam looks like, but just don't memorize the photos because they will not be the same. So don't rely on that. The text is in there if you want to use it in the website, in the web page on Canvas. Slides are basically from the book. I just condensed it down to the important stuff. Radiopedia. Okay, there'll be a website coming up on a slide. Is it my next one? It's not, but it is in the notes. There's a radiopedia.org. Really great tool to look at more pictures for some of these abnormalities. Okay? Get specific. If you just put shoulder fracture, you're gonna get all kinds of stuff, right? So if you're specifically looking for like a distal clavicle fracture, which we'll talk about, type that in there. It'll pull up different images for you to look at to see what it looks like. All right, Radiopedia is in the notes. Another thing for my testing, the notes in the PowerPoint slides. I don't pull questions from there. Everything that will be pulled will be from the slides. I don't pull factoids out of my notes. My notes are twofold. They're reminders for me to hit certain key points or kind of more detail to kind of explain something. And some of them are more in depth because they're questions that have been asked by previous students that maybe you'll hear me say a lot, stay on the lily pads in this course, right? Don't get down underneath the water into the weeds and the stems and let it pull you under. But some students will ask those really in-depth questions, so sometimes I put those in there for those students who like to read more, get more in-depth, and really understand some of the concepts behind it. Okay, so you do not need to study the notes in order to pass my exams. Everything comes from the slides. And then practice, practice, practice. Here's just some slides. It says 4th edition. It's the same concept, but it's the 5th edition now in Canvas. But if you want to search the book through that way, here's just some slides to kind of show you those examples, okay? It's in there for you. Okay. When I have sometimes pictures that are normal versus abnormal, I try to set them up like this, right? Where I always have, or attempt to always have, my normal on the left and my abnormal on the right as you're going through the slides, okay? Now again, this is another one of those you may be looking going, oh, well, yeah, there we go. This class is going to be easy. It will be. You guys will get it, right? But we're going to go through all this stuff. So as you can see, right, that's the abnormality, big yellow arrow. Won't have arrow signs usually, but that's showing you that. We'll talk about that dislocation later and which way it's going and why. This is all just intro stuff. More book stuff for you to use. I have that in there because somebody once asked me how to manage the book, but you can search by certain things like dislocations, like what that one was. Subluxations, we'll learn the difference in there. And here's an example of a question. You're like, wow, you're giving me one before we even get started. Yes, because I want you to see what this looks like. So, 37-year-old male is in a motor vehicle accident experiencing 9 out of 10 shoulder pain. X-ray imaging is accomplished and provided below. What option best describes the abnormality in the X-ray? So through my test taking strategies, I would have said, hey, jump to the question first. What option best describes the abnormality? Great, I'm looking for an abnormality. Okay, now I'm gonna jump to the answers. All right, alpha, right? Shoulder anterior dislocation. Oh, okay, well I know it's a shoulder, so I'm gonna hold off on that one and not cross it off. Salter Harris 5 fracture. You don't know this yet. By the end of the block you will. Salter-Harris is a specific pediatric type of classification of a fracture in a certain area. This is not a pediatric x-ray. Don't expect you to know that now, but if you were to see this on the test, you would already be able to cross off Bravo just by looking at the picture, okay? Charlie, femur dislocation.
No.
Yeah, there we go. All right, that's what I was looking for, okay. All right, delta left humeral fracture, okay, well, at least see a humerus on the x-ray, so we'll hold off on that. Left shoulder dislocation, I see the shoulder area, we'll hold off on that. I haven't even done anything yet with the vignette or even looked at the film in depth, and I've already knocked off 2 answers, right? I will tell you by the end of this block, you will be able to look at this right away, and you will be able to go, okay, is that a right or a left shoulder, right? The answer is left, so you will be able to rule this out as a right. We haven't even gotten anything yet, and you're down to 50-50. Now your job is to just figure out, is this a fracture or a dislocation, okay? So you see how sometimes looking at that question and those answers can play a big difference in getting you down to a 50-50, and you haven't even gotten into your interpretation yet. You just saved a bunch of time, okay? This systematic approach we're gonna talk about, correct patient, correct image, and kind of how do we go through this. I'm not gonna belabor it here because we're gonna get to it in a different slide, okay? But this is kind of the approach that I take. There's a million different ways to do this, but this is the process that I take, and we will go over it and cover it, okay? But there was your answer, left shoulder dislocation. But we got it down to 50-50 before we even started to interpret it and look for things. That one question, and for those of you who are syllabi readers and like to read the syllabus, that one question hit 4 points on my syllabus of things that I'm testing you on, right? I was able to test you to know the anatomy. I was able to test you to know plain film radiograph abnormalities. Could have asked you if I wanted to, based off of that, whether or not I should get MRI, CT, or contrast, and then any type of modalities or image production. It's all on there because you looked at an image, therefore it's image production. So it's really easy for me to do a simple question and hit most of the syllabus ELOs. You guys looked at subjective last semester in your SOAP notes, right? How to do like that patient history, questions asking, that kind of thing. Good. Radiology fits in your objective in this course. Why? Because you have the images. You're interpreting the images. It's an objective finding. There's no debate. There's no opinions. It's your opinion, but you're using it off of data that you have in front of you, right? So that's an objective finding. That's where that goes. When you're interpreting films, and you learn this in Clin Lab too, when you're interpreting labs, that's an objective finding. If you don't have the image, and you're like, hey, I want you to go get this shoulder x-ray, that becomes a part of your plan, because you don't have that data back yet. So when you're writing your note, which you'll learn more about this, that becomes planned, because I want you to go do this when you leave this office. But if I have the x-ray before you come in, that becomes objective, because now I'm interpreting it and looking at it. These are websites, again, to help you through here and through other stuff in this program. Radiopedia is really good. Okay, we talked about that. POCUS, pointofcareultrasound.org. Put that in your back pocket. That will be helpful when you need to EFAST exam stuff, but not right now. Orthobolus.com. Save that for your clinic. That is something that when you get out there and you have orthopedic patients that maybe don't need to go to ortho, you're trying to figure out, do I send them to ortho, do I manage it? Orthobolus is going to be magic. You're going to hear a lot more about that in ortho next semester. But they will pull up treatment plans based off of the fractures and the things that you're seeing on your films. Up to date is just a really good resource to just kind of check yourself. It's not always up to date, so be cautious with that. Don't use it for your papers. It's not okay. And then introductiontoradiology.net, I threw that on there because some people have like found it and came to me about it. You can use it, but be really careful. It gets in the weeds. It gets way deeper than you guys need as family practice VAs, okay? Don't use Wikipedia. Don't use Dr. Google, right? Please do not Google distal clavicle fracture on just Google, right? There is no reviews on that stuff. There's nothing stopping somebody from labeling something that's incorrect. I've seen multiple incorrect images from Google before that are labeled something they're not. I don't want you to read a film that you think it's something that you get confused. So use Radiopedia if you're looking for other ones. Do not use Google. Google will lead you astray. All right. All of that to finally get started. So, 6 hours of intro. We're gonna cover some of the intro of all this stuff. I'm gonna go into some of the history things, right? I don't need you to memorize years, like, oh, X-ray was invented in 1886 or whatever it ends up being, right? That is not helpful for you guys from a brain power standpoint, but I want you to understand how it came about, where it was around, because you are gonna have patients ask you questions about radiation. You gotta at least answer a little bit to it, be like, oh no, it's safe, don't worry about it. So we are gonna go over some of the physics of how it works too, so you understand that, all right? So, where does ionizing radiation come from? Gamma and X-rays. This is where it is on the spectrum of light and rays, right? So it's shorter wavelength, higher frequency, higher energy. We need it to penetrate the body, all right? So that's where it lives. We're just short of becoming the Incredible Hulk, all right? So no gamma rays, we're just short of that. Maybe another 10 years or so we'll figure that out. But higher frequency equals higher energy. So what it can do is it knocks the electrons out of orbit, creating an ion or charged particle, which means it also can damage our cells, and different severity based on multiple factors, right? How much radiation, how often are they getting it, what body part are we irradiating, what's susceptible to ionizing radiation, right? So we have these protective measures. Why are we covering this? Because you guys are the ones who are going to be responsible for ordering these things. You're in charge. You're deciding, do they get an X-ray, do they get a CT, do they get an ultrasound, what should I get? And some of these conditions, you can use different imaging modalities to get the same answer. So then the question becomes, well, based off of the patient population or what I'm imaging or what's going on, what's the best imaging to get, right? There's a clue into some of the possible stems you can see. What's the best? Yeah, X-ray, CT, and ultrasound for some of these things might all get you the answer. But what's the best, right? And we're gonna cover those situations of when do I do ultrasound instead of X-ray? When do I do CT instead of X-ray? When do I do MRI, or what am I gonna do? And that's a key part because you're the ones ordering the stuff. Part of what we end up using here is what are we trying to look at and how radiosensitive are our organs, right? So looking down at the bottom here, the low and fairly low radiosensitivity. That means radiation doesn't really affect them that much. Muscle, brain, spinal cord, bones, right? This is part of the reason why it is the primary study of choice, primary study that we're going to use when it comes to looking at bones, and sometimes muscle, but the brain we're going to talk about later on, spinal cord, like we can use that. Look at the high radiosensitivity. Lymphoid organs, bone marrow, blood, testicles, ovaries, right? Yeah, intestines are in there. Unfortunately, we don't have a better way to study those, but testicles and ovaries and bone marrow. I'm trying not to irradiate those things, right? Basically, the cells that have a higher or more frequent, what's the word I'm looking for? Tuesday morning. Replicability, right? They replicate faster, they divide quickly. Those are the cells that are more susceptible to radiation. Whereas muscle, brain, and spinal cord, how often at this point when you're an adult, how quickly does it divide those cells? Not very much, right? Your brain cells are your brain cells. You don't make more, that kind of thing. But in kids it does, so that's why kids are more susceptible to radiation than adults, because kids' cells are growing and dividing and multiplying much quicker than adults are. But my bone marrow, my blood, my testes, my ovaries, those are constant overturn. So they have a high radiosensitivity. It's the reason why they say the only thing that'll survive a nuclear holocaust is the cockroach, right? It's because their cells multiply so slowly that by the time, if radiation were to affect one of their cells, it would take years for it to mutate and divide and cause issues because of how slow the cockroach cell multiplies. And that's why they wouldn't survive. It's not because they're that tough, they're just that stupid, right? So just understand this chart here, understand what we're looking at, understand when we're concerned about certain things, because it might make you second guess the type of modality you're going to use. So when does this come in handy? When you're sitting on the test and you're like, I know I can do one of these things, X-ray or CT. Now they're both radiation, we're gonna learn one's more than the other. Which one should I go with? If they both give me the answer. Well, what am I testing? Maybe there's a better way to go about that, right? We'll see, we'll get into that. Blue slides. I have these sprinkled throughout for a couple of reasons. One, it's your kind of a little study tool in that aspect, like a check on learning as you're going through the slides afterwards. And it's a break to the black with the white writing in this dark, kind of mundane, course early in the morning. But it's there for that. Also in your Canvas, I have a review slideshow. That's for you. All that is all of these blue slides put in one slideshow for you guys for easy access if you want to do it towards the end of the block, just to kind of do a check on learning for you. That review slideshow is not end all be all. It's not 50 slides. It's not 50 questions. That is not what I want you to hang your hat on. But it's a good thing to do from a concept standpoint to make sure you understand the major concepts of the course. So sometimes I'll ask these, sometimes I'll kind of breeze by them because really they're there for you as you're doing your individual learning or individual studying afterwards. Every once in a while I throw in a bad cartoon. Right? So, alright. We just learned it magically. So if you were to get a question like this, lovely first order question that I can give you on the test. Right, I heard some people whisper it. Be confident, say it loud and proud. Testes, right? Most susceptible to radiation is the testes. It's the reproductive organs area there. So this would be one of those things where you're like, hey, some of these are in the same category. They are, but only one is from that category that is more susceptible to all the others. So this is where like maybe some is more right than the other. Make sure you're reading kind of what's going on. All right. Let's get into our plain films. Rankin-gram, that's how it's pronounced, rank-in-gram. It is a big fancy word for an X-ray because the guy who founded X-rays was William Rankin in Germany. So we're going to talk about attenuation a little bit, radiopaque, radiolucent, and orthogonal. These are all words that will be important as we kind of go through stuff. We're going to cover all these things, right? Some of it more briefly than others. This side is on every one of the modalities. Moving on. So 1895, Wilhelm Rankin discovered X-rays. First applications were industrial. It wasn't really used until 1896 when they started guiding battlefield surgery. Okay, it says right here at the bottom, all history slides are background info only. I'm not testing on the actual history stuff. This X-ray here is actually an X-ray of his wife's hands. He used her as the guinea pig when he was inventing this stuff. And there were no radiation controls back then, right? So it was just that. It got so bad that her hand started to like deform. Some of these are some of the deformities that are from the frequent X-rays and the lack of radiation controls that they had back in the late 1800s. So he did a number on her hands inventing this stuff. Yeah, she must have really loved them. I don't know. All right, but yeah, he did that to her. All right, this is what an X-ray machine looks like. Okay, there's two types. The first picture on the left is your radiology suite. That's what you see in your radiology department. Some ERs have their own radiology room that they can go and get X-rays on. The patient either lies on that table or in some cases stands in front of that board right there. The film is either behind the board or underneath the table. The X-rays come from this machine here, go through the patient, go onto the film, which plates now is what they're calling it. Film is kind of old school, but and creates the image. And we'll kind of talk about that a little bit. The one on the other side is a portable X-ray machine that will travel. That one you can take up, and you won't, but they can take up to the inpatient wards. They can do patients in the ER who are bedridden. They can take regular plain film X-rays without having to move the patient into this room here. It is lesser quality, right? It's not as good as the main machine, but sometimes it's all we have because the patient's not able to stand up or able to transfer to the bed, or it's a trauma situation. They just need the picture so you can they can continue to assess the patient. All right? These are two-dimensional images. Your brain is going to want to turn it into a three-dimensional image, right? You're going to look at it, you're going to be like, oh, well, this, the clavicle looks like it's laying in this way. It looks like it's over the spine or under the spine. It's a two-dimensional image, okay? If you want to paint a 3D picture, go back to that skull one I was showing you, you need two orthogonal views, basically at 90-degree angles, one from the front and one from the side, in order to paint a 3D image, right? Your brain is going to want you to do that. It's going to try to do it with one. You're going to need two. So we'll see some examples of that, and I'll be like, hey, which way is this? And you'll make a guess, and I'm like, I have no idea, you can't tell, right? And because it's just one picture, you need two in many cases. Another thing to kind of look at here is my tib fib over here, right? So you got my two views. So you can see how you might look and go, oh, what's going on? Like, is that hiding? I can't see that. Why is the fibula sitting over there? Well, then I get my second view and now I can see it from the side. So if I had a foreign body sitting here in the tibia, I would have no idea how deep that is. Is that in the bone? Is that in the soft tissue? Is that on top of the bone, behind the bone, in front of the bone? I don't know. And that's where you would need this picture to kind of see where is that foreign body in relationship to the frontal view, because it's only a 2D picture. For example, is this hand a right hand or a left hand? Think about it. I'm not going to make you answer it now, because then I'm going to say, what about this one? Right? Huh? One or two, better or worse? Right? I have no idea why. The bones look the same. I don't know how the patient is sitting. Look at where my thumb moves. It's different depending on which way my hand is placed. Now, I will tell you, per protocol, the x-ray should be shot like this. But you don't know how they did it. There's no way to know how they did it, right? And so that's the problem with this if I don't have a nice little R or L on my film. So when we see pictures like that, you have an R or an L, that's telling you right or left, because you can't tell. Now we jump into this one. True or false, same hand?
True.
There is a context clue in here where I can tell you that it is not the same hand. And here's why. I do this, right? If I were to flip one of them and kind of do it, I can, when I have both of them, I can look at my radius and ulna and see that they're both being shot appropriately. Because when I flip, my radius and ulna near my wrist are going to flip as well. So because I have them both thumb side and kind of aiming this way and not two thumbs out here, I can safely say that it's not the same hand. But that is way more advanced than I need you guys to be. I'm just letting you know, don't get tripped up and just look at these two things and be like, oh, those must be different, because individually you cannot tell because you don't know, right? Unless there's a right or left. There are a few things like the shoulder, the hip, okay, that you can't tell right from left, and we'll talk about how, without a right or left marker. But if you have just a forearm, just a tib fib, the bones look the same. There's no way to tell the difference unless the tech told you if it was a right or a left. YouTube doesn't work in this classroom. Medical Center of Excellence, good stuff. That's a video for you if you want to watch a short video. I think it's only like 2 or 3 minutes of how x-rays are produced, what the concept is behind the physics of the machine, that kind of stuff. We're going to briefly cover it, but it just tells you how they work if you're interested in something like that. Okay. So how do they work? So ultimately what ends up happening is the cathode up there at the top, all right, creates a bunch of electrons. It shoots it towards that spinning anode, it hits that, the electrons basically burst and turn into photons, which is radiation, and it shoots it down towards the body part. Now, what you see behind the hand is the film, or the plate, and then what happens is the radiation penetrates the body part. Different tissues and different levels attenuate that radiation film, or that radiation power, and changes the shadow that shows up on the film. This is a game of shadows, right? Why do things look the way they do? The more radiation that is absorbed by the body part on plain film x-rays, the brighter gray or brighter color or more radio opaque that part is going to be. The less radiation that is absorbed, which means it's gone through the body part and has reached the film, will be darker or more radiolucent, okay? Any radiation that hits the film without hitting body part makes the color black. So what we're really looking at is a game of shadows. So when I go back to this, all of this black around the hand, that was radiation hitting the film that did not touch any body part, because that's what turns it black. The bony area absorbed some of that radiation, so less of it got to that film, which is why it's brighter white or more light gray, because less of the radiation penetrated through and got to the actual plate in the film. That's what it's showing you. So that's more of a game, like I said, it's a game of shadows in that aspect. The less radiation that gets to the film, the more white or grayish it's going to be. Does that follow? I know it's early. Okay. So, with that being said, right, this is kind of a chest x-ray. I know we're not covering chest in this block, but it's a good picture kind of showing you how the patient can be lying down and the x-rays come down and the film is sitting right underneath here. Yes, it's not lined up. I'm aware this is a staged photo. They did not make sure that this is sitting underneath, so they're missing all that, but not important. And standing up is the same concept. The film is sitting in this machine, sitting right back here. The radiation comes this way and hits the patient. Okay? We'll go more into this one in block 2, but what it talks about is magnification, right? Having things close to the film is important. So for example, the heart is a very large organ, right? Which means if we play the shadow game, I'll try to do this to where everybody can see. I'll do it on both sides. If we play the shadow game, so for those over here, you see the shadow of my hand, right? Here's where the x-ray is. As I bring my hand farther away, what happens in the shadow? It gets bigger, right? It magnifies. So I got my hand up here. Let's say the wall is the film. My hand is the body part. I got my x-ray machine as my phone. As I bring my hand farther away, you see how it gets bigger? It's a game of shadows. That's magnification. So magnification will happen the farther away your body part in question is from the actual film, right? So it's one of the reasons, if anybody's ever got a chest x-ray, we always do it with the patient facing the film. I want you up there because I want the heart as close as possible because I want a real picture of what the size of that heart. When I flip you around, it gets magnified because now I have extra space there. So the heart is going to look larger on that AP x-ray than it is that PA. Right? We'll dive more into that in block 2, but I want you to understand the concept of magnification is important in interpreting the films, right? Here's a side lateral film, again. PA, so we'll say, frontal view basically, but if I were to see anything on there, this is not a 3D image. I don't know where everything's sitting. I'll put up an example. Doesn't the heart look nice and beautiful in center? But how deep in the heart is that? How deep in the chest is that heart? I don't know, right? From this picture, I can't tell. It can be anywhere in here. But then when I go here, the heart is nice and anterior like it's supposed to. We'll talk about more what happens when the heart projects onto the spine and stuff like that later. But it's just showing you, again, 2 pictures, lateral views, and frontal or PA views on most of our stuff. CT versus MRI. How many say they look the same? Say it in your head, it's okay. If they do right now, that's okay. That's okay. We're going to look at enough of this stuff to where by the end you will know what's a CT and MRI. How can I tell the difference? Well, one thing I'll point out is, first of all, you're ordering it, but what if you didn't order it? What if I ordered it on your patient because you were on leave? And then you come back and you just have the images, right? You didn't order it. This is a CT or an MRI, right? So a couple of key things to look at this one, right? So CT is radiation, MRI does it, but they also look at different things, right? MRI is a study of like really looking at things of soft tissue, cartilages, things along those lines. So what we have here is, big difference is a graininess kind of to the CT, is the best way for me to describe it, compared to the MRI. Now I'm comparing them to one another, right? So when I say graininess, I just mean compared to the MRI. Look how smooth the MRI is, all right? Look at how well defined the soft tissues are in the MRI here when I look at my muscles, okay? I see the striations almost. I kind of can make the muscles out here. I know they're muscles just because I've seen enough of these. You will too by the end know that they're muscles. But it's not as clear cut. It almost looks like a TV from like the 1970s, right? It's kind of got that like fuzzy, kind of grainy, snowy kind of appearance compared to the MRI. However, look at how wonderful I can see the femoral head and part of the pelvis sitting in here on the CT, right? That really stands out really nicely. I can really make out the details on that bone. I kind of see the femoral head. So here's that same area, but you notice how the bones don't pop as well as the CT does, right? Look at how bright white the bone is compared to the MRI. But then when I flip to the MRI, look at how pretty this area is here. So that's my labrum. All right, look at how nice I can kind of see that little bright white area for the labrum. I can't make that out here. I know where it should be, but I can't see it, right? CT is used more for bone. Okay, in this block, we're going to use it mostly for bone. We'll talk more about what it can be used for as far as in the abdomen, a little bit in this block, but then more in block 2. MRI is used more for your soft tissues, your labrums. Talk about the knee, right? Your menisci, your ACLs, your tendons and ligaments, the things that we think are torn. That's where your MRI is going to be used. Okay, I'm not going to make you interpret MRIs. I am, except for like one situation, which we'll go over that when we get to. But I'm not going to give you a hip MRI and say, tell me if the labrum's torn. Don't need to worry about that. But you do need to be able to tell the difference between a CT and MRI. If I give you an image, is it a CT, is it an MRI? Okay. What does attenuate mean? Right? That's the different levels of absorption of the radiation. The radiation beam is being attenuated based off of the body part that's in there. Okay? So reduced energy as it passes through the tissue. That's attenuation. You're going to see this slide multiple times. I'll leave it at that. Okay. Know and understand how tissues appear on X-ray. X-ray and CT. Okay? Radiation type images. Air is black. Metal is white. Bone is not white. Metal is white. Bone looks white, but it's really a very light gray. Right? It's a very, very light gray. Because in order for it to be white, all of the radiation must be absorbed. Metal, or reflected, either way, right? Metal reflects it. Bounces right off of metal, right? So that's why you get 0 gray whatsoever behind metal on an X-ray, because none of those photons, none of that radiation got through the metal to the film, it all reflected off. So metal is white, bone is a very light gray. I want you to write this on top of soft tissue in your notes. Write the word fluid. I haven't thought of a way to edit this picture yet. Fluid and soft tissue are the same. They look the same on X-ray. They are this nice medium gray, okay? Down at the bottom, you see radio-opaque and radiolucent. That just shows you, depending on what direction you're going. If I'm going in one direction, I have more radio-opaque, brighter gray, right, towards white. Something's more radio-opaque. If something's more radiolucent, it's a darker gray, towards black region. When comparing two objects, those are really good descriptor terms. If you're talking to another colleague, you're talking to ortho, you're talking to a radiologist, you're like, hey, do you see this more radiolucent line in the shaft of the left humerus about a third of the way down, that's what I'm looking at, right? These are some of the ways you're gonna start talking to your other colleagues to help them pinpoint, this is what I'm looking at, help me see what I'm seeing, tell me that I'm right, or whatever discussion we're gonna have. But put fluid up in here because you're gonna see a little bit later how fluid and soft tissue appear the exact same on X-ray and CT and Y. Okay, so let's go over how those different tissues appear. How many different, and this is a rhetorical question, how many different densities do you see on this film? Right? So first, I'll draw your attention to what's truly white. The jewelry that the X-ray tech should have taken off the patient before doing the picture. Right? Earrings, necklace. Earrings and necklace, right? The metal, bright white. Okay, so that's the first part. Now I'm going to draw a couple of transition lines here. So the first one that I know is standing out to you guys is the difference between bone and soft tissue. Okay, so I'm going to erase that again. So bone and then soft tissue. So look at the difference in the grays between the inside of the bone and what I circled. Now here's another transition line. And even here, I'm going to put a circle here and put a circle there. Look at the differences in densities between those two things. One of those is skin and subcutaneous fat. The other one is muscles. You can see muscles are more dense than fat. So that's why it ends up being a little bit more radiopaque, because there was more attenuation in those tissues than there was the subcutaneous fat and the skin. Does anybody know what muscle this is? That's the deltoid, right? You will not be able to see it on all patients, right? By nature, the more fluffy someone is, the harder it is to get these nice distinguishing muscles versus subcutaneous tissue, okay? But it just goes to show you the differences in density. Look at how much darker this area is compared to anywhere else in the body. Why is that? Those are lungs, right? Yeah, it's full of air. There's still some tissue there, some lung tissue, but it's mostly air. So because the radiation flies right through air, hence the black all around the shoulder, it's going to be more radiolucent than it would be if there was more tissue there. Does that kind of track? Understanding the physics behind some of that? Now, is this a right or a left shoulder?
Right.
Right there. Big ol' R. Right, and I was in this question every semester. Well, what if the radiology tech labeled it wrong? I can't help you there. Right? That's on them, that's not on you. There's nothing you can really do about that. The good news is, this is probably why you ordered the picture, so it's probably the right side, or correct side. Right? Big old humeral neck fracture there. What does the JT stand for? Anybody know? Yeah, it's the X-ray tech's initials. So that way, if there's an issue with this film, we know who did it. We go, hey, we need you to redo this. Or hey, this looks a little weird. Can you tell me where there's some complications? It looks magnified. Is there a reason they couldn't get up there? Like, what's going on? It gives you a person to reach out to, or for the radiologist to reach out to ask questions about like how this was shot, just in case there's something kind of funky with it. What do the beads mean? Anybody know that? Standing or flat. So what's going on with this patient? She's lying down. These beads are loose. Not all markers have this, but I just want to point it out because it'll help you out when you're looking at stuff. These beads are loose in there, so because they're pulled in the center, the patient's lying down because they just laid that right marker right on the table. If they were standing up, they would have to stick it on that standing kind of platform we looked at and grab you and bring those beads right to the bottom of that circle. So it's another way to tell if they're lying down or standing upright without the word upright on the film. So just nuances for you, because there are times when normally shoulder x-rays are done standing up. Well, this tells me that this patient couldn't do that. Maybe it was shot in the bed in the ER or something. She couldn't stand up. It was a trauma, and they were busy doing other stuff. How do I know that? The little beads right there in the center. Yes, sir? productive time. Yep, thank you. All right, on that note, take a 10-minute break and we'll come back at the top of the hour.
You moved. I was looking around. I was like, dude,
I did.
where the fuck is he? I was like, no, I was like, there's no way, man.
I appreciate the faith. Yeah, I was like, yeah, the sea was open, and kind of tired of. So yeah, I was gonna give this a go. And if I don't like it, I'll just move back. Because no one's fighting that sea.
Yeah, I could see that, how that'd be kind of frustrating to be that close.
Yeah, it wasn't bad. It was just, it's okay.
Well, next soreness, I get it.
Yeah, how was your break?
That was good. Good. I had family here for probably too long.
Okay.
Yeah, my mom surprised me with extending her flight. And I was like, oh, I'm so happy. Thank you for doing that.
Without telling you.
Yeah. Going to the grocery store, I come back, she was sitting in the car. It's like, oh, I changed it to a Friday. Perfect.
Like,
Because I was trying to get some family time, just my wife and my son,
yeah,
you know?
yeah.
And, yeah. But it's all good.
Yeah, I know what you mean.
Yeah.
There's I think Ben Franklin said, company and a fish are the same. They both start to smell after about 3 days. It's like, but even, yeah, it's tough. Like, yeah, you love your family.
Yeah.
I get it, but
But you got to spend that time with them too, you know?
yeah.
How was your break?
Yeah, got a lot of time with family.
Yeah.
Did stuff around the house that I've been meaning to do.
Yeah.
Worked on my truck a little bit. It's good.
Nice.
Yeah.
Did your brain start to go crazy, not like getting that stimulation like we were in class? No?
Not at all.
Dude, I was like, I need to do some Sudoku or something, man. I was just like sitting on the couch like, I'm just
This
bored.
song.
Yeah.
Yeah. The first little bit, I was like, it took a second to kick in, but man, I just know that the Army always takes its time. So I just wanted to rest. I kind of had to force myself
Yeah.
a little bit.
Good for you.
Yeah, it was well spent.
Yeah. Did you take leave or pass?
I took a pass.
Yeah.
I did like that pass from Saturday to the Tuesday, and I only had like 1 day of duty.
Yeah.
Which wasn't bad.
It was. I'm just listening right now. Cohen sent your name on the sheet.
Yeah.
Like that was best way to earn a paycheck right there. Easy.
Oh yeah. It was funny. It's like $20 a name. Yeah, it's a good business.
Yeah.
Keep you at home.
I'm glad it was that easy because my buddy who just graduated, he said like, yeah, the day in the middle of passes, he's like, we had to go in and like stock the lab and do some stupid shit. So I guess he got lucky.
Yeah.
Hopefully that's the way it should be, honestly. Like,
Yeah, it's like what's in.
trying to de-stress us. You know, it's the least you can do.
Yeah.
Least they can do is approve them on time. I don't know how much stress you had.
Mine wasn't too bad. I did have to I put it in. It took me a couple weeks, but I wasn't down the wire or anything. Was it like that for you?
Sunday night, and I was like gonna have to come in on Monday potentially, like because it didn't get approved. They kept kicking it back. One of them was I was local all the time, right? And I said that they kicked it back. They wanted itinerary, breaking down day by day, like local, whatever. So I kick it back. I add that. Somebody else kicks it back. A different person looked at it and said, "You're local. You don't need an itinerary." So they kicked it back again. That was the third time they ended up kicking it back, but.
Yeah. It's like communicate.
Yeah, that was the biggest frustration because some people theirs got approved without that stuff and got approved first time. Just there's no consistency.
Yes. That's frustrating.
It was, but I look back and PA school is being paid for. I was like, I can deal with this stress
For sure.
Like, hey, life is good.
Yeah, it is good.
Just try to have that perspective.
That's a good perspective. I really appreciate it. It's just, but still, it's like,
It's the Army though, It's
Yeah.
a surprise too much.
It's tough. That's such a balance.
Yeah.
It's like never really balanced at all. It's usually the other way where it's never working.
Yeah, which I learned my lesson. I'm gonna put in my leave for December, like probably this week.
Yeah.
Yeah.
Yeah, I've got a couple of buddies get married like in November. So just probably just get it done.
Yeah. Is it like I think starting Veterans Day, things like look really good for us.
Yes.
Yeah. It's like it opens up. Is it after that point or?
It's like just before.
Yeah.
It's like the 1st and the 8th.
Okay. So the 8th, that's right before the. I think it's like the 11th. So that is that on maybe a Thursday?
That's 8th. I think is the 7th. Yeah, it's that Saturday.
Oh,
Yeah.
that's perfect then. That'll work out.
So that'll be good. I got a buddy getting married 5th. So yeah, it's like I'm curious to see if they feel this or not. I really like that.
Yeah.
But
I wouldn't mind one class. Like, okay, take a little bit of stress off, but don't
They
put
said
the same.
they were.
Oh, they're not going to?
I made a Kelly for my for the history. It says that they were trying to take out one of the alarm blocks because it's so beat.
Yeah.
But you said they're not going to this semester.
I wouldn't have mind one more. But hey, it's looking real good. Yeah.
oh yeah, that'll be a nice segue into Christmas.
Yeah.
Another lesson I learned when it comes to this like and stuff is so I put in, like I said, I didn't start mass until Saturday.
Yeah.
But I thought we were gonna have to come in on Friday, and I had made plans to go to the beach. You know, with my family leaving Thursday afternoon. I was like, am I gonna have to come back in, or am I gonna have to wait to leave and just waste about a day?
Yeah.
And so now on, I'm just gonna do leave. Like,
Yeah.
I'm not playing around. Just get it done.
Yeah, one day to come out.
Yeah.
Yeah. I agree with that. I'm not even gonna worry about saving these. It's not worth the stress.
That's okay. It is better for you.
Can't see anything though. See that?
Oh, like can't see. Oh,
man.
Details.
Keep moving forward and see if it changes the picture at all. Like just pick the camera up and move it.
Oh yeah, like to that front one. Any better?
Not better.
Yeah.
How do they do it in the last class? Is it up in the front row? Is it? Oh, okay. I don't know if you're gonna leave it
It
up there.
doesn't change that much.
But
Yeah.
This can be a hard class to record. We were putting it on. You missed the first question.
Did you put right?
No, I put wrong. I said I thought it was saying like what is the most. It's on the slide. The top of the slide. I told you I'm so freaking right now. Like I am so hungry. Like everything's just
Did you go out last?
Alright, let's take our seats, let's jump back in.
My sleep score was like a
Configuring stuff. Alright. Couple of things too, I was looking at the schedule. We're like 0.8 or like 1,500 like this entire first block. Beautiful. It's okay. So, one thing I want to put on your guys' radar too for the exam. A couple of things that I forgot to mention, I'll mention as we get closer. There are some people who bring in like this one guy right here, like these monitors and stuff. You're welcome to if you want to, right? That's allowed. And then what's unique about my exam over every other exam in iPad, you can zoom if you want to on the pictures. We allow that in this course. With a caveat, if you're zooming in so far that you're like, is that a thing? You're probably zooming in too far. And that's probably not an abnormality I'm asking you to find, right? So the zoom can be beneficial depending on the size of some of your screens. While I admit that, it can also be a hindrance if you're not cautious with it of what you're trying to evaluate and find. So police yourself right? If it's so pixelated that you're trying to figure out if this is an X-ray or a scene from the original like 8-bit Mario game, probably zoomed in too far, come back out and take a better look at it. Also, review for the exam. Yes, I offer a review. No, it's probably not like a review that you're used to, right? I don't come up here and pull up a slideshow and go through like review type stuff, okay? But what I do is I offer you guys the chance to clarify confusing points. So I'll come in, right now we're slated for hopefully that Friday after the PAP test over lunch. It is optional. We'll talk closer when we get to it. But the way it comes in is I come in here, whoever wants to come, comes. You don't have to if you don't want to. I have all the slideshows pulled up, and I'm like, all right, what's confusing you guys? What do you need more clarification on? Somebody raises their hand. Hey, slideshow 4, slide number 17. Can you pull that up real quick? Sure. Pull it up. Here's my question, right? And then I go and I point it out. I try to explain it more. Because I can stand up here and go over things, but that may be things that you're all like, well, I already knew that. That wasn't beneficial to me, right? So I want to make it beneficial to you guys on answering the questions you have a couple of days prior to the exam to help you understand the concepts better. Also, lab. Our lab is just in here. In this, like I think you have clin skills that day anyways too. So whatever the UOD is, but this is not a lab that like buys you PT gear, unfortunately, because we're staying here. And what that lab will look like is the first hour or so, and possibly the second, depending, is going to be practice, like practice kind of reviewing films. It's either going to be me or the ortho instructor is going to come in here on this block and have a different slideshow that just goes over different fractures and how do you describe it and how do you talk about it and how do you do it to kind of give you that little bit of a practice in that aspect. So that's kind of what that'll look like. I think those are all the key points that I didn't mention before, and I'll hit it when we get a little bit closer. All right. So does everybody see how the different tissues appear? I like this X-ray, right? Because you can see air, you can see subcutaneous fat, you can see the soft tissue, i.e. the muscles, you can see bone, and you can see metal. So you can really see the different levels of density on a film and how each thing has its own kind of look, okay? So, here's another one. Okay? Here's another one. What's going on with this patient? What do they have done? Alright, total knee, right? And the big old metal knee replacement there. Okay, great. What are these along the soft tissue? Those are staples. How do I know they're staples and not sutures? Look at, they're white, right? Sutures are tissue, or not tissue, like cloth, like a vinyl, right? So sutures you may not be able to see, but staples you absolutely can. Good. What are all of these? I gotta get used to this working again. I'm excited. What is that? And that, and that, and that, and that. Yeah, so the medical word for that would be subcutaneous emphysema, right? Air in the soft tissue or in the subcutaneous tissue. Is that a problem? Maybe? Do we expect it to be there? After surgery, yes. I'm not concerned because I see staples there. What does that mean? That means they opened up this dude's knee or gal's knee and they put the replacement in there. Well, when you open up the body part, air gets in, they close it up, that air will dissipate. However, if this didn't have staples and this didn't have a total knee replacement that was recent, now I'm concerned because how the heck did air get into the subcutaneous tissue of the knee? No idea, I need to figure that out, right? So, in this patient though, not concerning, but it just goes to show you that sometimes air can be in places where it's not supposed to be, right? And it still shows up as more radiolucent than the soft tissue. Right? The soft tissue doesn't overload it. It's still there. Like there it is. It's more radiolucent. Is it as black as the surrounding areas out here? No, of course not. But it is radiolucent enough to stand out against that soft tissue because the air is sitting in there. So once again, I ask, what color is air on plain film radiographs? Black. What color is metal? White. Bone? Yes, light gray. And then soft tissue, a darker gray, grayish. Remember, soft tissue and fluid, same color. Same color, okay? All right, so what are the pros to regular plain film radiographs? And when I say plain films, I mean regular x-ray, taking a picture of something, okay? And yeah, it's inexpensive, super, super cheap, readily available. Even in your deployed settings, you guys are gonna have at least a portable x-ray machine, right? Maybe not if you're outside the wire or something, but anywhere that has a medical team is gonna have at least a portable x-ray machine, at a minimum. So you're gonna have it almost anywhere you go, right? There it is, portable, quick. The cons are, it is ionizing radiation, right? We don't like to use radiation unless we have to. There is no such thing as a safe amount of radiation. It's a risk versus benefit ratio. Bless you. Risk versus benefit ratio, right? X-rays and plain films are very low amounts of radiation, but nothing is without its risk, okay? 99.9% of the time, the benefit for a plain film x-ray outweighs the risk of the little bit of radiation you're going to be getting, but that is a con, all right? What do we use it for? We'll talk more about the chest and the abdomen in block 2, but it is the first line for most chest pathology. You're gonna notice how that's yellow. We're gonna see the difference between yellow and blue here in a little bit on my words. But for this block primarily, skeletal system, foreign bodies, and trauma, okay? It is the first line study for almost all musculoskeletal pathology, fractures and arthritises. That's what your plain films or your regular x-rays are going to be. Your first line study for almost all musculoskeletal pathologies, okay? You can still use it in the abdomen for bowel obstruction or free air in the abdomen. Chest is first line for a lot of pathologies and tube placement. These are all the things you can use plain film x-ray for. You know, we talked about the gravity with those beads. That was to lead into this, right? So looking at abdominal x-rays, you can see how positioning is important and understanding kind of what we're ordering and why we're doing it. These are 2 films. One of them is lying down and one of them is standing up, okay? Look at the one that's standing up and how I have these nice horizontal lines. There, okay? Again, there, and there. And then when I look over here, I mean, this is gonna be a large summit, but outside of that one, like I don't have those lines throughout this part of the intestine. Why? These are what called air fluid levels. Okay? So when you have, I got my coffee in my office, anybody got a bottle of water? No? Like an actual clear bottle? Alright, thank you. I need to bring one. Perfect. So, when you have fluid and water, right, how it shows up. So if I am lying flat, and let's say I had a little bit of water in here, and the water lays out, and I'm shooting an x-ray down, all of that fluid is going to be in the x-ray path, right? It's all over. But when I stand it up, I have a fluid level, and now I'm shooting the x-ray this way, I can see how high the fluid goes before it stops, and I have that flat line, right? But if I lay the patient down, it spreads out, and it's everywhere. But then once I stand them up, gravity pulls all that fluid down, and I have a line where the fluid stops, and that's what that fluid line is, those air fluid levels. Thank you. All right, so it just goes to show you how positioning of a patient and gravity can make a similar image look different and give you different information. On top of that, when I stand you up, what's going to rise to the top? Air, right? All the air is going to rise to the top, all the fluid is going to go down to the bottom in some of those areas. So we'll be able to see air in parts of the body that maybe shouldn't be there. But weight-bearing pictures. Okay? Look at the difference in the joints. If this first one with the white arrow, they're not weight-bearing. They're sitting on a table, their leg is straight out, they just took the picture. You can order a knee that way. That's okay. But look what happens when I have them stand up. Now, which one do you think is better, white arrow or blue arrow, if I'm trying to assess the cause for pain and functionality of the knee joint? The blue arrow, right? Because most of the time, the patients are probably experiencing pain when they're standing or walking or putting the weight on there. All right? So weight bearing in your lower extremities, your knees, your feet, is almost always more preferred than non-weight bearing. Because I will tell you right now, if you order a non-weight bearing knee x-ray and you find out the patient needs ortho, or a foot x-ray and you send them to ortho, and you don't have weight bearing, they're just going to send the patient to get weight bearing, and they're going to get more x-rays. So save the time, order weight bearing, but it just goes to show you how the difference in position can make a difference in the film, right? Both of these feet x-rays, or foot x-rays, feet x-rays, whatever, are weight bearing. I want you to focus on the white arrow. Look at the gap. We're going to learn what this is called later. But look at the gap compared to the lack of gap there. Right? So in a normal foot x-ray, you should not have a huge joint gap there. There's a ligament in there that puts that all together. When that ligament is disrupted, the joint spreads apart when you're standing on it. Here's the fun part about this particular abnormality, which is called Lisfranc fracture, which we'll learn about in a later lecture. If you don't order it weight bearing, you'll miss it, because that only separates when they're putting weight on it. So if you didn't order a weight bearing foot x-ray, it would look like the first one, even though there's a ligament disruption. Right? So that's where I get into anatomy and physiology. Understand what you're looking for. Understand what you're assessing, because that'll kind of help you walk through of like, what do you need to order in order to properly assess the area of concern that you're worried about. Flexion extension views, right? Looking for the functionality of the cervical spine. These are all just different kinds of views that you can get. Now look at that L on the extension. See those little beads and how they fell down there? That's what I was talking about. How you know this patient was standing. They fell to the bottom of the circle. Right? These cervical spine x-rays, right, we don't get them as much anymore in this aspect with the flexion extension because we have CT now. And we'll go over why we do CT when we get to that area. But often this is helpful to determine whether or not the spine is fully stable, or if they're having any issues with their joint spaces kind of sitting in here, so you can get these flexion extension cervical spine views. Rotation is something we need to be concerned about. So we talked about magnification. These are all patient positioning films, right? So they're upright, going back and forth. Now with the chest, right? I want them, I'm turning my back to you because I'm showing you, nice and straight. What happens if they're like this? Or like this, right? It can throw things off. So understanding your anatomy and what you're looking at will help you understand that. So spinous processes here, but these clavicle edges should line right up with the edge of my sternum. If I end up seeing something like this, right, my first brain thought goes, oh my God, is that sternoclavicular joint dislocated? Why is there a huge gap there? First of all, it's really hard to dislocate that joint, but it can be done. Actually, it was just in an episode of The Pit. But it can be done, but it's very hard to do. But my context clues become, okay, I have a gap. Do I have something else to explain that gap? Oh look, my other clavicle seems to be almost infringing on the spine. Is that actually in over towards the spine? Well, probably not if my clues are, hey, look, this one's in and this one's out. It's probably a rotation of the thorax. Now, if this left clavicle lined up perfectly with the sternum, right in here, now that might be a dislocation of that sternoclavicular joint, because I have the gap, but then I have this one where it's supposed to be. So it's probably not rotated. That and they will hurt right there. It will be painful in that area. So patient history, context clue as well. But just know to look for the rotation in order to make sure that your abnormality is not actually an abnormality, is just a positioning problem. Orthogonal views, we briefly talked about it, but this is really why they're important. If I had just the image on the left, this doesn't look that bad, right? I got my fracture right there, but for all intents and purposes, it looks like it's pretty well aligned. It doesn't look displaced. I don't have any major issues with this forearm x-ray until I get my orthogonal view, and now I see it from the side. So this in here, it shows you how important it is to make sure you get that AP or PA, depends on the body part. I don't need you to get hung up over that. That's not for you. That's for the x-ray tech to know how to shoot it, right? So, but that and the lateral view together is what gives you the whole picture of the patient. Because if you just had that first one, it would not look as severe as it actually is. And I know a lot of you are turning around, you're going, well, I'm gonna see the patient in the office, so obviously I'm gonna know their arm is bent in a funky direction. So why does that matter? Again, I get to the point to where there are times when you see images on patients that either aren't yours, because you're following up for somebody who's deployed on leave or something like that, or you're seeing images on a patient that is yours, but you weren't there because you were on leave or something, and it just, somebody else took care of it, and all you have is the picture, you don't have the patient in front of you. Or, especially when you're in phase 2, or for some of you who end up going to the ER, if you end up specializing in ER stuff, when you're in that area, a lot of times the nursing team will see the patient, order the x-rays, have them done before they even get brought back to a bed. So you have images before you've even laid eyes on the patient. So a lot of times you may see this stuff to where you didn't see the patient first before you got the imaging. Or my favorite is, they went to urgent care of the ER off base, then they came to see you to follow up, and they brought the images in so that way they can be uploaded into the system. You didn't initially see the patient, and maybe they've already shortened it or corrected it, and now it's straightened out again. Well, what did it look like originally? By the time you see them, it's already where it needs to be and casted up. So, use those orthogonal views. Alright, there's only one drawback. We talked about plain images, that it's ionizing radiation. It's cheap, it's readily available, it's portable, it's quick, right? And then why are we using it? You guys got that slide that shows us why we use it. And then just understanding how positioning can impact your image. Those are your key points so far. Okay, questions so far? Alright, you're going to see these slides multiple times through this lecture and the next lecture. This applies through both lectures. Contrast agents. So we just spent time talking about, I told you on multiple slides, right fluid with soft tissue, right? Right fluid with soft tissue, because it looks the same on x-ray. What does that mean? That means on an x-ray, I can't tell the difference between fluid and soft tissue. They are the same density. They are the same radiopaqueness, radiolucencies, whatever you want to call it, right? They look exactly the same. That's why on an x-ray, when you see the heart, you just see this gray blob of the heart. There's blood in there and there's muscle, but I can't make out the difference between the two because it's just the same density gray blob of the heart. So when we want to see things from a vascular standpoint, or we want to visualize things better, we have to use something called contrast. When you have soft tissue areas that have either fluid or other pathways in them, you have to use contrast in order to actually truly visualize that area. What the contrast is designed to do is to basically separate the soft tissue from the cavitary regions, whether it's blood in a vessel, whether it's intestines, whether it's the bladder, sometimes the uterus, more like the fallopian tubes, things along those lines. We give that contrast to help visualize it better. There are certain contrast agents that are better depending on what we're looking for, all right? So your IV or IA, it's very rarely do we use intra-arterial contrast, but technically we can. But your IV contrast is an iodine-based contrast specifically used for the opacification of vascular structures, solid abdominal and pelvic organs, right? Livers, kidneys, pancreas, those kinds of things, okay? So your angiograms, your arteriograms, your venograms, levangiograms, and IVP, we'll talk about IVP in the second block. But that's what those are used for. No. Well, I already gave you the answer. Patients who are allergic to seafood can still have contrast. No, it's not the same iodine. No, there's not cross-reactivity. You will get that often. I'm allergic to shellfish. That's okay. It's not the same kind of iodine. This has been studied over and over. There is no indication that the contrast used for radiological studies has any cross-reactivity with those who are allergic to seafood or shellfish. So it is safe for those patients to use that. If they're super freaked out about it, give them like a Zyrtec or something beforehand. I can't just take this before your exam. But there is no indication of cross-reactivity between those. That is a very common question from our patients. Now, if we're trying to evaluate things that are going to be on the GI tract, right? Which means our oral or rectal, yes, I said that right, oral or rectal contrast is barium-based. This is the entryway, right? I'm giving the contrast via IV or artery, usually IV, venous, is iodine-based. If I'm making the patient take the contrast orally, i.e. drinking it, or rectally, i.e. the opposite of drinking it, but going up the other way, it's barium-based, okay? We use this for most abdominal and pelvic CT scans, unless we're concerned about a bowel pathology or perforation, okay? The reason for that is in red. Barium is not a water-soluble contrast. If it gets into the abdomen, it's gonna cause an issue because it doesn't just absorb. It's not water-soluble. So if you're concerned for a perforation in the esophagus, in the stomach, perforated ulcer, in the intestines, do not give the barium to get that contrast. You'll learn in phase 2, there's another type of contrast they can give that is water soluble. It's not as good as the barium. For here though, based off what the book is, barium is still what they're teaching academically. You'll learn about that other one when you get out to phase 2. Because barium is still used in a lot of places because the other stuff's really expensive and not every place can afford it. Barium is super cheap, but you do not give barium if you're concerned about a perforation. And then when you get in your cavity space, that's still iodine-based contrast, right? Same stuff, it's just different because what we do is we inject the contrast directly into the area that we're trying to evaluate. So a cystogram, bladder study, right? Contrast goes up through the urethra into the bladder, and we take pictures. Urethrogram, same concept, you just take pictures of the urethra. Hysterosalpingogram, anybody know what that is? Big fancy word, right? HSG, so fallopian tubes. So that's looking at the fallopian tubes. We'll give contrast and it'll fill those things up. We'll look at what that looks like later on. And then myelogram and arthrogram, so like joint type stuff. Myelogram's more the spine. So if anybody's ever had an arthrogram before, if they're evaluating like your shoulder labrum or your hip, what they do is they inject iodine contrast into the joint capsule and then send you like immediately for an MRI. And the contrast is actually directly into that cavity space. But those are all still iodine-based contrasts. So what have we learned so far for plain films? It's all iodine-based unless it's the GI tract, then it's barium. Alright? Okay. Here's a problem with the iodine-based contrasts. When I pump it into your veins, it gets filtered by the kidneys. If there are things that are causing degradation of the kidneys, that's a problem, and we need to be concerned about that. So, if they're dehydrated, it's going to be hard for the kidneys to push out that contrast. The biggest things, diabetes or underlying renal failure or insufficiency. If they have kidney failure, do not give them iodinated contrast. You will zap their kidneys. You can actually put them into an acute episode of renal failure by giving them contrast if they have degraded kidney function. So do not do that. Yes, sir.
Is that an absolute contraindication then?
Full absolutes, yeah.
Relative absolute.
Yeah, relative absolute is fair, yeah, right? Obviously, there are going to be situations where you're like, listen, if you don't get this scan, they're going to die. So, like, kidney function be damned, I need to know what's going on, right? So that's why I don't use always and never in medicine, but for the most part, if they have degrading kidney function, you're not giving them iodine contrast. Diabetics, right? Why diabetics? You haven't had farm yet, so I'm gonna give you a pass on that. It's more the medication and not the diabetes. The medication they take is extremely hard on the kidneys, particularly the metformin. And it takes a lot of work for the kidneys to filter out the excess of that medication. So diabetics, we don't want to give the contrast to unless you can discontinue the nephrotoxic medications 2 days prior to the test. So if they're a diabetic, and there's other medications that are nephrotoxic, not just the diabetes meds, these are just one of the more common ones. You can look at them and say, hey, we really need to get this study, so 48 hours prior to your exam, please stop your diabetes medication for the 2 days, and then go ahead and get your exam. And then usually they can start it back up again the next day. It's usually not that big of a deal because the contrast will filter out pretty quickly out of the kidneys. But doing them both at the same time can be really too much for them to go. And it says non-essential nephrotoxic. So like the diabetes, right, guys? If they're on metformin, it's essential for their diabetes, but it's not going to harm them to be off of it for 2 days. But there are other medications that are nephrotoxic that you will learn about that may be essential for life and their condition. So if you can't stop that medicine, because let's say, I'm just spitballing here, I don't know, it's some seizure medication, and if they're not on it, they have seizures multiple times a day, well, guess what? You're just not gonna get the contrast. I'm not gonna tell you to stop your seizure medication just to get a CT scan, because that could be ill-suited for your health or possibly life, depending on what that condition is. So understand that nephrotoxic medication stoppage is only for non-essential ones, but you can do it that way as well. And then, so you'll order the renal function panel prior to ordering the studies, or ordering the CT, we talked about that. Hydration. You have got to counsel them, even if they're healthy. If one of you in here gets a CT with contrast, you should be counseled to be having excess hydration for 24 to 48 hours afterwards to help the kidneys flush it out, right? Lots of water, help flush those kidneys out, help them work to get that contrast going through. That should just be standard kind of patient counseling in that aspect. Here are some more risk factors, okay? Contrast-induced nephropathy, what ends up happening is a creatinine will increase by 25% from baseline, You'll learn it more in Clin Lab, but know that if you end up having a healthy patient, let's say you got the labs, you got the kidney labs, everything looks pretty good, right? And they come back in for follow-up, and for whatever reason you order more labs, and you notice that you've increased at least 25% from that patient's baseline. The reason it says baseline and not a number is because every patient's gonna have a different baseline creatinine in here, right? It's gonna be different for everybody. So it goes up by more than 25% of that baseline, now you have contrast-induced nephropathy. That contrast caused inflamed kidneys, decreasing kidney function. How do we fix it? Hydration, monitoring, try to get it cleared out, and hopefully it'll go back to normal. But here are some more risk factors of getting that contrast-induced nephropathy, right? Over 75, why? Because they're old. Right? Stuff stops working. Even if they're healthy, they're 75, stuff stops working. Allergies or asthma, hypertension. Why hypertension? Because hypertension can be caused by the kidneys. It does wear on the kidneys. So everything reports back to the kidneys in some way, shape, or form. But these are all the things that can cause contrast-induced nephropathy if it happens after an exam, and that's your definition of the at least 25% baseline, right? Or an increase in, 25% from baseline. Now we're getting to allergic reactions. Anaphylaxis. This is real. This can happen. I've had it happen to me when I was a CT tech twice, right? And it was a patient who had no prior history of contrast reactions, didn't have any issues with it, and they ended up going into anaphylaxis. Again, no evidence of cross-reactivity of shellfish allergy, okay? If they have lots of drug allergies, I'm allergic to penicillin, and I'm allergic to ACE inhibitors, and I'm allergic to this, it should kind of red flag a little bit in that aspect. But you can have a reaction to the contrast. So you have your mild, your intermediate, and your severe. Here's what I'm going to tell you from a clinical standpoint, okay? If you have a patient and you're going to give them a CT, your next question is, have you ever had a CT with contrast? And say, yes, I have. Great. Have you ever had any issues, any reactions, anything like that? No. Fantastic. If they say, yes, I did. Okay, what happened? I just got really kind of itchy. Okay, any rash, any hives, anything like that, no, just itchy. Don't give them the contrast, right? Because these reactions get worse and worse with each time they get exposed to it. Now, ask the clarifying question, because most of the time what you're gonna hear is, yeah, I felt really weird. Like I felt warm and like I felt like I peed my pants. That's normal. That's what the contrast makes it feel like. Because it's hot. The contrast is viscous, so they warm it up. So it's hot in the syringe. And so when it goes into the veins, it's warm. And it's pumping through your whole body. So you get like this warm sensation. And then as it filters through, right, where does all this contrast go? The bladder. So it gets really warm in the pelvic region. And no joke, patients think that they wet themselves. Because it just gets really warm down there. That's not an allergic reaction. That's a normal variant of getting a contrast CT. But if they say that they were sneezing, that one gets overlooked so often. Yeah, as soon as I started the exam, I sneezed. And I had a sneezing fit for like 3 minutes and then it went away. No more contrast, right? Sometimes they'll get like small little rashes, things like that. The nice part about the mild thing is the treatment is just supportive care. Problem is the intermediate, right? Angioedema. I love how angioedema is an intermediate reaction. Hypotension, urticaria. The biggest thing is you got to get meds on this one. Epi is going to be given, then some Benadryl or diphenhydramine, and then the severe one is where they code. Hopefully that doesn't happen to anybody here, because you're going to ask the right questions and you're not going to get contrast to anybody who's allergic to contrast. So you just got to kind of ask those questions in that aspect to get more clarification on it. Here are some other risks and complications of contrast agents. Extravasation. What happens here, right? They're going to come and see you afterwards. You can't stop this. This is when a vessel blows. You're not getting the IVs on these patients who are getting your contrast. Usually what ends up happening is they went in for a CT. Yes, this is an x-ray, but they went in for a CT. They got their IV to get their contrast. For those of you that don't know, they don't inject it by hand. It's a machine that pressures it into the veins. So that way the CT tech's not in there when you're scanning all the radiation, right? And so they step out and they hit the button and it just starts injecting and the vein blows. And so that contrast just spills out into the soft tissue, right? Nice part about it, warm compress, multiple times a day, couple of days, they're gonna bruise up, it's gonna be painful, but the iodine contrast is water soluble, so it will get reabsorbed and everything will be okay. But they're gonna come in and probably follow up with you afterwards, going, because the scan didn't happen. Do I still need to get the scan? Should I try the other arm? What's the story? And you gotta kind of let that go away, and then I would still order it, but then educate the patient that it's a risk, right? The vein blew, give it another chance, use the other arm, you can still get it done, that kind of thing. If it doesn't go away within a couple of days, you can talk to the radiologist about it. They may have some other methods, but most of these extravasations here, because it's iodine, it's water soluble, it's just in the soft tissue, like I said, it's gonna be painful, it's gonna bruise up, a lot of warm compresses, a couple of days, it'll kind of go down and it'll be gone. But this is something that can happen. I wouldn't throw this in as a standard patient risk. You would tell them beforehand when you send them for the scan, because it is pretty rare. It's really just based off of how good of an IV do they get. So most CT techs are pretty good at getting the IVs, so it doesn't happen very often. So more of just follow-up type stuff. Okay, here's a different machine. So technically, fluoroscopy, computed tomography, and mammography are all considered plain films, right? It's just regular radiation like we've been talking about. We'll talk about CT and mammo a little bit separately, but fluoroscopy for sure. So what this is this is a little portable machine, okay, that is used for procedures mostly. Procedures and in surgery. Because what it can do, everything we've looked at has been a snapshot in time, right? Just a single snapshot. What fluoroscopy can do is give you live pictures, right? So you hold the button down and you can move the hand and move things around and you can see it moving on the screen. And then it has the ability to take what's called spot films. So at any point in time, they're like, okay, there, click, and it still saves the x-ray in the system, but you can still do it with movement, right? Which makes it great for image-guided procedures. If you're trying to inject the carpal tunnel, right, and you're trying to make sure you're in the right spot, fluoroscopy is a great way to go. Because you can actually watch the needle go in, make sure you're injecting in the right spot. Those arthrograms we talked about with the shoulder injections, they use fluoroscopy, and they are using live x-ray to take a look at it as they guide the needle to make sure it's in the capsule before they actually inject the contrast, so that way it's in the right spot. That's when you're gonna use this kind of stuff. They also use it in surgery. So that knee replacement, they'll use it in surgery while they're putting the knee replacement in to make sure everything is all set up. They don't do the whole thing and then take the picture and hope that it's in the right spot, right? They're doing it live time. The catch with that is that you have higher radiation than regular x-ray, because it's not just a picture. It's continuous radiation while they're watching that movement and doing that. So you do have a higher amount of radiation. And like I said, mostly use ortho procedures, so that would be more like injections and surgeries. Cardiac, we'll take a look at that. Hepatobiliary, so liver, kind of gallbladder area. Some GI, not really. IR, interventional radiology, so that's where they can like go in and like put stents in the heart and grab like little clots and stuff like that. They'll use the fluoroscopy so they can watch the wire go all the way up where they need it to go to do what they're doing. So here's an example of that hip injection I was talking about. You see the needle right there, right? Look and make sure they get it right into the capsule before they inject that contrast. That's how they can use the fluoroscopy. What you see there on the right is the fluoroscopy arm in surgery. It's got its own little sterile drape. It's a pain in the ass. Because if it touches anything, they gotta take the whole thing off and put a new one on. So stay away from that when you're in the OR. Don't touch anything. Literally walk in like this and just do this when you're in phase 2. Don't touch anything. And what'll happen is the surgeon will come over, put your hands up, and they'll be like, you just keep your hands there until they tell you to move it. Yeah, don't scratch your nose. Because if you contaminate anything before the case even starts, get out. Get out of here. So they will let you help as long as you're very careful and just don't contaminate things before the case starts. You did it, got kicked out. It's okay, you just come back the next day and try again. That's all good. Alright, so here's what the cardiac procedures look like. Right, so what they did is they actually started this down in the femoral area, and they go up and they trace it all the way up into the heart. And what this guy is, so you can see they're pumping a little bit of contrast in here in alpha. That's a little bit of contrast kind of floating out, right? But then they got this the claw, like from Toy Story in there, right? And it can grab the little clots if it needs to, and then this guy can place a stent in there in Charlie as well. So it's super cool stuff. If you get the chance and your phase 2 site has an IR department and you get the chance to use an elective in there, you'll see some pretty cool stuff if there's not something else you like otherwise. So if you're like, I don't know what to pick, and they have it, be a good one to do. You see some pretty neat procedures. Hepatobiliary pathology. So this is where they inject contrast into the hepatobiliary tree, and they're checking for flow up into the liver and through into the intestines. The black arrow is showing you a stricture right there. There may or may not be a stone in that area, because what I have here is I have a lack of the contrast, and then look at how dilated this common bile duct is. It's not usually that big. I know you guys don't know that yet, right? You'll know that in practice or whatever, but this is the abnormality here, but it's just showing you that we can use the fluoroscopy or even the contrast for hepatobiliary pathology as well. GI pathology, this is more contrast type stuff in fluoroscopy. This is the esophagus, right? So what are we doing here? This is something called a barium swallow. So what happens is they're having issues. Maybe they're like, hey, I eat and I got something stuck here in my throat, or it feels like I have something stuck here, like right in the middle of my chest. So we got to figure out what's going on when you're swallowing. Is everything working the way it's supposed to? So what they do is you order what's called a barium swallow study, right? And we'll cover it more in block 2. But what it does is they drink this barium contrast and they're filming you drinking it, right? And they're watching the stuff go down the esophagus, making sure the epiglottis gets out of the way, and it does all that. And they'll do it 3 different ways. They'll do it with this liquid barium, right, which is a little bit thicker, but it's like a liquid. Then they'll put some powder in like a pudding, and they'll make you eat the pudding, because that's a different consistency. Then they give you a pill that's barium, and you watch it go all the way down. So they're testing liquid, chewed up food, and solids, and seeing where your issue is. And that's used with this barium contrast, right? But anyway, barium contrast, I don't care about kidney function, because it goes through goes through like the GI tract, right? It doesn't get processed through the kidneys. But hydration is still really important because I need the intestines to push this stuff out so it doesn't kind of solidify up in there. So hydration is always important after the contrast. We talked about the risks. The risks are the kidney function, right? That's the biggest thing, and most importantly, the allergic reactions, the anaphylaxis. Uses of fluoroscopy, we talked about the image-guided procedures for the most part, cardiac procedures, maybe some hepatobiliary stuff. We'll talk about some specific hepatobiliary exams in a couple of lectures of how to evaluate for that, and then the GI stuff like the barium swallow. And then Lego Batman, because everything Lego movie is cool. And if you don't think it's cool, I'm sorry. Go watch them again because they're super fun. Questions? Yeah, right. Normally I would take this next 10 minutes and go into the next one, but it is one Tuesday morning, and it's your first lecture of the semester. I will hang out here for a few other questions. I know this stuff is a little bit thick right now, but I've got to give you all the intro stuff before we get into the fun part of actually like reading and looking at the images and everything. So bear with me. Bring me your questions. I'm happy to answer them and help clarify stuff. Other than that, we'll see you guys at 1 o'clock. Welcome back. Thanks for your time. Please get up now.